Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. I noticed that many patients come to the clinics asking about insulin resistance and asking to have a test for insulin resistance because they go through the internet and suspect that they may have insulin resistance, particularly in fertile women and women with polycystic ovarian syndrome. That's why I constructed this short lecture to highlight this topic as recommended in modern practice. We have to discuss some issues or some points, which are what's insulin resistance, etiology, and sequelae, symptoms, signs, diagnostic tests of insulin resistance in PCOS. Is it a cause or an effect? And therapeutic agents for insulin resistance, in addition to some conclusions. So insulin resistance simply is a stage of prediabetes, which means that there is a state where more insulin is required to obtain the biologic effect achieved by a lower amount of insulin in the normal state. So the body should have more insulin. Why more insulin? Because either suboptimal response of tissues to physiologic amounts, the receptors, or downregulation of insulin receptors in response to hyperinsulinemia. And these are the main causes of a requirement of more insulin in such a case. We have to know that insulin has three target organs in the body, which are liver, muscles, and adipose tissue. Insulin helps glucose to go inside the muscle, inside the adipose tissue, inside the liver. In the liver, it leads to formation of glucagon, and the muscle will go to the muscle, accumulate in addition to amino acids, and free fatty acids go from circulation to the adipose tissue in addition to glucose. So the insulin has a crucial role in regulation of glucose level of the body. In cases of insulin resistance, the insulin is ineffective in its normal amount or in its physiologic amount due to failure of these receptors in the organs, which are liver, adipose tissue, and muscles. The resultant will be hyperglycemia, which is a stage of prediabetes, which may lead to type 2 diabetes. This means that glucose uptake by the muscle, while the adipose tissue and liver is impaired. Also, in the liver, the change of glucose to glycogen is impaired as well. So there is increased gluconeogenesis and increased glycogenolysis. So no glycogen, more glucose, and more glucose in circulation. Moreover, there is increased lipid storage in the liver and in the muscle. And this will lead to impairment of insulin signaling and energy homeostasis. The total results of this abnormality, which is insulin resistance, is increased plasma level of glucose and increased free fatty acid, because no mobilization of fatty acid to adipose tissue, so increased free fatty acid, and glucose uptake is impaired due to impairment of liver, muscle, and adipose tissue uptake of glucose. Moreover, in the liver, there is decreased 6-hormone binding globulin production, and this will lead to increased free testosterone. So this is the first cause of hyperandrogenism in patients with insulin resistance. The second mechanism is increased insulin growth factor 1, which also contributes to hyperandrogenemia in such a case. So don't forget that insulin signals or insulin receptors mainly affect these three organs: adipose tissue, liver, and skeletal muscles. In normal muscle, as I already told you, there is good insulin response good signaling. So this stimulates glucose uptake to the muscle through a chain of intracellular events. But in muscle insulin resistance, there is no insulin signaling. This will lead to increased lipid intake and blocking insulin signaling pathway, and this will lead to hyperglycemia in addition to accumulation of intracellular fatty tissue inside the muscle, which prevents proper insulin signaling and uptake of glucose. So in insulin resistance due to muscle problem, there is block of insulin signaling and accumulation of intracellular lipid. What about normal liver cell? Insulin binding will increase glucose uptake by the liver. It will be changed into glycogen, and there is lipogenesis also in the liver. But in cases of hepatic insulin resistance, there is impairment of insulin binding to the hepatic cells or hepatocytes, and this will lead to accumulation of glucose inside the hepatocyte and promoting lipid synthesis. So there is increased glucose, glycogen, and lipid production in the liver. And this will lead to excessive storage of lipid in the liver, and this may contribute to what's called non-alcoholic fatty liver, which is commonly seen by radiologists in many patients, particularly obese patients. Moreover, the white adipose tissue increases free fatty acid. High fatty diet blocks insulin stimulation of AKT phosphorylation in the liver, and high fructose diet suppresses glucokinase activity and glycogen synthesis. So high fatty diet is not good. One of the contributing factors of hepatic insulin resistance. High fructose diet causes hepatic insulin resistance, and adipose, white adipose tissue also, which is obesity, can lead to hepatic insulin resistance. Again, in obese patients, there is an important event, which is inflammation. And actually, there are three inflammations. Unlike normal adipocyte with storage of energy by binding of insulin to the adipocytes, glucose uptake increase, suppresses lipolysis, and promotes lipid synthesis. In obese patients, there are three inflammations. Adipocyte inflammation, increasing macrophages and neutrophils, and this will lead to increased cytokine production by the macrophages and leads to inflammation. Also, there is decreased leptin signaling, and leptin is the satiety hormone, which leads to failure to feel the sensation of being full. And in obese patients, despite increased lipid in circulation, there is lipid resistance due to decreased lipid signaling. In addition to gut inflammation, dysbiosis or alteration in the gut microbiota. All these are microbiota in the gut. All these are three inflammations that are associated with obesity. So obesity is one of the causes of insulin resistance. Obesity will lead to inflammations, and this will lead to systemic insulin resistance and problem in adipose tissue. We have to know that obesity, general obesity, which is measured by body mass index, for example, is worsening the insulin resistance. So insulin resistance does not mean obesity. Insulin resistance is abnormal adipose tissue in the apple form, which is around the stomach, visceral obesity. This is insulin resistance. While the obesity is not mainly adipose tissue, is not condensed in the around the abdomen or in the abdomen, but around the hip, buttocks, and thigh. So for insulin resistance obesity, we have to measure the waist circumference and waist to hip ratio. And it has been found that waist to hip ratio In females, if it is more than 0.8, this is insulin resistance, a criterion of insulin resistance. We have to measure waist circumference and hip circumference. If the ratio is more than 0.8 in females and more than 1 in males, this is a diagnostic of insulin resistance, unlike obesity, which is measured by body mass index. But we may have some patients in the clinics who are lean individuals, and actually they have insulin resistance. How can you explain this insulin resistance in lean individual? Actually, in those cases who do not have adipose tissue, excessive adipose tissue, but they may have decreased muscular mitochondrial density and biogenesis. And this will lead to decreased mitochondrial activity in the muscle cells, which has been estimated to be around 40% in the lean individuals of parents with type 2 diabetes. And this will lead to increased lipid and muscular or muscle insulin resistance. This may be a genetic cause. So this is a broad definition of insulin resistance. What is the etiology and sequelae? The etiology is excessive weight. Obesity, particularly visceral or abdominal obesity, is the greatest risk factor for insulin resistance. So if you see an obese individual, particularly with visceral obesity, increased waist circumference, increased waist-hip ratio, this patient is liable to have insulin resistance. Patients with excessive carbohydrate intake, some genetic families, some patients with increased aging, particularly more than 40 PCO patients with more than 40 years due to mitochondrial damage with aging, and of course, sedentary life. So those patients are liable to have insulin resistance. If they have insulin resistance, is not just polycystic ovarian disease, as many patients consider that it is, I don't need children, I don't care about insulin resistance or PCOS because I have enough children, I have regular cycles, I don't feel any problems. No, this is not the case. Insulin resistance may lead to a plethora of problems. The least is polycystic ovarian disease, menstrual irregularities, and infertility, but they may have some inflammation of the liver, atherosclerosis, low high-density lipoprotein, liver cirrhosis and liver disease, metabolic syndrome, hypertension, cardiomyopathy, elevated blood pressure, elevated triglycerides, and increased intra-abdominal fat. So the sequelae of insulin resistance are serious and maybe life-threatening. If we neglect this case and we don't care about this case, this is not good. So you have to highlight to the patients that insulin resistance is not just PCO morphology by ultrasound or symptoms of menstrual irregularities, but it may affect the whole body. And one of the important issues is metabolic syndrome, and the metabolic syndrome is diagnosed by increased blood sugar, increased blood pressure, increased triglycerides, decreased high-density lipoprotein, and increased waist circumference, as already mentioned. What is the cause of insulin resistance? Actually, I told you obesity. Overnutrition is the most common cause because overnutrition leads to lipid storage in the muscle, in the liver, in the adipose tissue, and this will lead to inflammation and impaired insulin signaling, in addition to increased glucose and increased free fatty acid in the circulation. And you can see in such a case, there is increased some parameters like leptin, tissue necrotizing factors, and IL-6 and other, with decreased adiponectin. Also, in this figure, you can see that insulin resistance is not just a simple disease. It may affect the heart, the cardiovascular system, liver, kidneys, cancer, and other serious diseases. So take care that it is not just a simple word to say that you have insulin resistance, And the results due to increased lipid storage in muscle, liver, adipose tissue, with impairment in insulin signaling and energy homeostasis, and subsequently increased blood glucose, and subsequently type 2 diabetes and increased free fatty acids. What are the symptoms of insulin resistance? The patient may have craving for sweets and salty food, may have fatigue, frequency of micturition, tingling sensation, hands and feet, increased hunger and thirst, and darkening of the skin, in addition to weight change and high blood pressure. Signs: increased waist to hip ratio, increased waist circumference, more than 35 inches in females, blood pressure increase, fasting blood glucose more than 100, skin tags, decreased high density lipoprotein less than 40 in men and less than 50 in females, increased fasting triglycerides more than 150 milligram per deciliter, patches of dark velvety skin under the arms and or the neck, which is called acanthosis nigricans, in addition to some cases of retinopathy. What are the diagnostic tests? Patients coming to asking about, I need to test if I have insulin resistance or not. Some doctors go directly to HOMA insulin resistance. Here you can see in this figure that HOMA is just supportive, is just surrogate marker for insulin resistance. Insulin resistance is measured by measuring glucose tolerance test to see how quickly exogenous glucose delivered by oral, intraperitoneal, intravenous administration is cleared from the blood, which is test of insulin sensitivity actually. Also, insulin tolerance tests to examine the systemic sensitivity of insulin receptors by measuring blood glucose levels after IV insulin administration. So these are the measurements of insulin. In addition to hyperinsulinemic euglycemic clamp, which is a gold standard method to assess insulin sensitivity in vivo. So the first test is to measure the glucose and to do GTT, which are 4 measurements. Fasting after 1 hour, 2 hours, 3 hours after the dose of glucose. Surrogate markers, HOMA, IR, HOMA2, and other tests, in addition to increase the triglycerides and decrease high-density lipoprotein. Don't forget to order for triglycerides and high-density lipoproteins, because decrease this protective high density and increased triglycerides is not good, is a marker that the patient has insulin resistance. In addition to calculation of HOMA insulin resistance. Here in this figure, you can see that insulin resistance is a pre-diabetes, actually, before type 2 diabetes, where there is increased insulin production, but there is no response. So the blood glucose starts to increase despite increased insulin production due to resistance to the insulin by the receptors, and this is insulin resistance. But after some time, the insulin production decreases, and this is diabetes. So insulin production increases, pre-diabetes, insulin production decreases, this is definite type 2 diabetes, and this, again, insulin resistance continues in type 2, of course. And here is the calculation of HOMA, which is homeostasis model assessment, insulin resistance, by measuring fasting glucose and fasting insulin multiplied to each other and divided by 405, less than 1, less than 2, less than 3, as you know. And here is HOMA2 calculator, which is a program in the computer. You can measure the blood glucose, insulin, and make an index to see if the patient has insulin resistance or not. And these are surrogate tests. They are not the main tests. Other tests you have to measure, as I told you, triglycerides, high density lipoprotein, fasting glucose. High level of fasting glucose alone is good indicator of insulin resistance. Increase some hepatic markers is not available. Increase leptin, resistin levels, decrease adiponectin, and some growth factors which are not commonly used. So these are the common diagnostic tests, mainly GTT, don't forget. Insulin resistance in PCOS, is it a cause? Is it an effect? We have to know that PCOS is increasing over the world and reaching up to 25% of women worldwide. And the main pathophysiology of PCOS is disruption of insulin metabolism in addition to hyperandrogenemia. And those patients at risk of insulin resistance, as I told you, obesity, sedentary life, genetic, familial, excessive carbohydrate intake, and age more than 40. In PCOS, there is alteration of insulin signaling, which already mentioned in insulin resistance. So the insulin signaling to the three vital insulin responsive tissues is impaired, which are liver, muscles, and adipose tissue, leading to decreased glycogen synthesis and decreased glucose uptake, increased insulin growth factor 1, decreased 6-hormone binding globulin in the liver, decreased insulin uptake in the muscle, increased lipid uptake in the muscle, decreased glucose uptake by the adipose tissue, increased lipid accumulation, and decreased lipid decomposition. And these effects on the adipose tissue are enhanced or favored by excessive androgen. And this is particularly in the visceral tissue, as I told you, visceral adiposity, not systemic adiposity. The impaired insulin signaling in these three vital tissues will lead to insulin resistance, of course, and hyperinsulinemia. And this will lead to impaired hypothalamo-pituitary-ovarian axis and hypothalamo-pituitary-ovarian adrenal axis. And this will lead to change of the gene-rich pulsatility from the brain. So the whole hormones affected by gonadotrophins will be affected. ACTH will increase, LH will increase, may TSH, maybe other hormones from the pituitary affected by the pulsatility of the gonadotrophin releasing hormone, and this will lead to increased LH-FSH ratio and ovarian morphology of PCO, as you see by ultrasound, and increased antimullerian hormone from excessive follicular growth in the follicular phase. So these are sequelae of impaired hypothalamo-pituitary-ovarian and hypothalamo-pituitary-adrenal axes. And the ultimate effect of increased these adrenal and ovarian hormones, increased insulin growth factor 1, decreased 6-hormone binding globulin, is hyperandrogenism or hyperandrogenemia. So the PCOS is disturbed insulin signaling with insulin resistance in the three tissues and affecting this endocrinal milieu and with reproductive failure and subsequently hyperandrogenism. So don't look to the ovarian problems or the infertility or the menstrual problems alone. It is a part of an algorithm of effect of insulin resistance, hyperinsulinemia, hormonal imbalance, and hyperandrogenemia. There are some studies found that insulin resistance found in around 70% of cases of PCOS, and not only obese patients up to 80%, okay, who are body mass index more than 30. And some studies mentioned in almost all obese patients, insulin resistance is found. But what about lean patients? Up to 25% of those lean patients have insulin resistance, despite no obesity. And this may be due to insulin signaling problem at the level of cells and insulin receptor dysfunction. And don't rely on body mass index as a measure of obesity. As I told you, visceral obesity and lean individuals may have a small body mass index, but they have insulin resistance, and you have to check for insulin resistance in all cases. What is the cause of hyperandrogenemia? I told you, decreased sex hormone binding globulin, increased insulin growth factor 1 in the liver, direct effect on fecal cells, impaired of hypothalamus, pituitary, ovarian, and adrenal axis, and some studies found increased messenger RNA. If you look to this patient with typical PCOS, you don't have to look to the ovaries only. You have to look to the patient, the whole patient with hair distribution, hirsutism, hair loss, and acne, hair on the back, obesity, increased cardiovascular risk, insulin resistance, excessive weight, waist circumference, dark pigmentation of the skin, and acanthosis nigricans, in addition to menstrual problems and infertility. So don't look to infertility and misperiod and ovaries by ultrasound only and neglect the whole individual. And some studies found that we have to classify the patients with PCOS as different phenotypes, and PCOS alone with menstrual irregularities and infertility is found in only one phenotype, which is type 3, but the three phenotypes have insulin resistance and hyperandrogenemia with skin and dermatological symptoms. Don't forget to search for the systemic manifestations of insulin resistance as shown in this figure. Again, you have to know that more than half people with polycystic ovarian disease develop type 2 diabetes by the age of 40. This is another risk for those cases. You have to take care of the patients with insulin resistance and PCOS. As I told you, with insulin resistance, increases insulin production until a certain level, and then insulin decreases, and this is diabetes. What is the treatment of insulin resistance? If you diagnose insulin resistance in a patient with polycystic ovarian disease, what's the best treatment? Actually, there is no best treatment. The objective is to decrease lipid storage in the muscle, in the liver, in the adipose, in the liver cells, and increase insulin sensitivity, decrease lipolysis, and decrease inflammation. These are the targets. What is the drug that achieves all these targets together? There is no drug that can achieve these objectives all. If you see this interesting figure, you can see that the best treatment is lifestyle modification, weight loss, exercise, increased physical activity, healthy diet, and this is half of the way of the success. But if you go to the drugs, you have to think of insulin sensitizers. Metformin, of course, decreases glucose production, increases glucose uptake by the liver, by the muscle, by adipose tissue. Also, other sensitizer TZD groups also are considered insulin sensitizers. You can give insulin if the patient has bad GTT, and insulin in such a case will overcome the insulin resistance. You can give sulfonylureas that stimulate insulin secretion. You can give glucagon-like peptide 1 agonist or peptidase 4 inhibitors. I'll discuss this later on. And also you can give bromocriptine and dopamine D2 agonist. Also the effect on the brain and the intestine by probiotics, and sodium glucose co-transporter 2, which is the major co-transporter involved in glucose reabsorption in the kidney. You can give inhibitors to avoid reabsorption of glucose. All these are drug groups, but a healthy diet and exercise with reduction in the overall caloric intake and reduced consumption of high fat, high fructose, and high processed foods remain the most effective weapons in the fight against insulin resistance and diabetes. Don't forget that metformin is one of the best insulin sensitizers, but there are some studies on leptin sensitizers and therapies of mitochondrial dysfunction on the way, and incretin hormone, which is secreted from the intestine to enhance the effect of insulin on glucose and oral intake of glucose, and has been found to be 3-fold time greater if the glucose is administered orally than intravenously. So incretin hormone drugs that increase incretin hormone maybe gastric inhibitory polypeptide GIP, which comes from duodenum and jejunum, or GLP-1, which is glucagon-like peptide 1, which comes from the distal ileum and colon. And actually, the GLP-1 is more stable than GIP, and both will lead to lowering blood glucose by inhibiting glucagon release and stimulating insulin release. There are many drugs that GLP-1 agonists, which are incretin mimics, like commonly mentioned by the patients, Ozempic, Saxenda, Mjaro, and others. These are GLP-1 agonists that mimic incretin to enhance the effect of insulin after oral intake of glucose. And actually, this GLP-1 is inhibited by an enzyme which is called dipeptidase 4, which is DPP4, and this enzyme inhibits the effect of GLP-1. So if we give DPP4 inhibitors, we will inhibit the inhibitor effect on the GLP-1, and these inhibitors will have long-term blood glucose regulation and reduction of micro and macrovascular events like galvus and other groups of this, other drugs of this group. Importantly, to highlight the leptin, which is the satiety hormone, giving us the sensation of full. Some drugs are important that work like leptin, and these are under research. But you have to know that in obese patients, despite increased leptin, which is the satiety hormone, the central effect is impaired due to obesity. So these are the therapeutic agents, but in conclusion of this short talk, I would like to say that insulin resistance has been noted consistently among many women with PCOS, especially in those with hyperandrogenism, but it is not included in any of the diagnostic criteria for PCOS. We have to put the insulin resistance as one of the important criteria for diagnosing PCOS. There is no medication superior to the others as a specific and universal agreed for line of treatment for insulin resistance, but don't forget that lifestyle, as I told you, exercise, diet is the best treatment so far. And in the era of precision medicine, we have to individualize lines of management if the patient has risk of cardiovascular disease, risk of liver disease, and others. We have to highlight these risks for every individual patient, and our work should be patient-centered and not disease-focused management. Thank you.